Your blood type is one of the first pieces of biological information ever recorded about you, typically noted at birth or at your first blood draw. And for most people, it has occupied a very small portion of their medical awareness ever since. It appears on forms. It determines what blood can be transfused safely in an emergency. And beyond that, it has been treated as a fixed, inert, genetic characteristic with no particular relevance to the day-to-day business of staying healthy. The research picture emerging from the past 2 decades of large-scale genomic and epidemiological studies is somewhat more complicated than that. Not in the direction of the popular blood type diet, which I want to address directly at the start of this video. The idea that people with different blood types should eat fundamentally different foods has not been supported by the clinical evidence, and several studies, specifically testing the diet's predictions, have found that its purported benefits apply equally regardless of blood type. That is not what I am here to discuss today. What I am here to discuss is a different and more substantiated set of findings. The epidemiological associations between ABO blood group genetics and specific cardiovascular, thrombotic, metabolic, and neurological risk profiles that have emerged from studies involving tens of thousands to hundreds of thousands of participants that have been replicated across independent populations, and that point to specific biological mechanisms through which the genetics underlying blood type classification may influence the behavior of specific physiological systems. These associations do not mean that blood type determines health destiny. The effect sizes are real but modest, and they are entirely overridable by lifestyle. What they may provide is a specific lens through which some individuals can understand their starting point for certain risk categories and make proportionally more targeted decisions about the lifestyle investments most likely to matter for them specifically. Before anything else, what I share in this video is educational information only. It is not medical advice. Blood type associations with disease risk are population-level statistical observations, and individual outcomes are determined far more by lifestyle, environment, and other genetic factors than by ABO blood group genetics alone. What I want to give you today is an accurate, evidence-grounded overview of what the research actually shows, with its limitations clearly stated. I am Dr. Andrew Carter, and I have spent 15 years working exclusively with adults over 60. Understanding which aspects of cardiovascular, metabolic, and neurological risk are modifiable is the central project of the preventive medicine I practice, and if blood type genetics inform which of those modifiable factors deserve the most attention for a specific individual, they're worth understanding. If this is your first time on this channel, subscribe right now because every week I bring you specific, grounded information about what your body needs after 60, and this video addresses one of the most discussed but most poorly explained topics in popular health media. Let me begin with the biology of what the ABO blood group system actually is, because most people know their blood type, but very few understand what it represents at the molecular level, and that understanding is necessary for the health associations to make biological sense. The ABO blood group is determined by the ABO gene, located on chromosome 9, which encodes glycosyltransferase enzymes that add specific sugar molecules to the surface of red blood cells and other cell types. Blood type A individuals add N-acetylgalactosamine to the H antigen surface structure. Blood type B individuals add galactose. Blood type AB individuals have both enzymes and add both sugars. Blood type O individuals have a non-functional version of the gene and add neither, leaving the H antigen unmodified. The critical biological point is that these antigens are not only on red blood cells. They are expressed on the surface of endothelial cells lining blood vessels, on platelets in saliva and other secretions, and on various epithelial surfaces throughout the body. This widespread expression of ABO antigens on cardiovascular and hemostatic tissue provides the mechanistic foundation for the associations between blood type and cardiovascular and thrombotic outcomes that the epidemiological research has documented. Additionally, the ABO gene region of chromosome 9 is in linkage disequilibrium with several other genetic variants, meaning certain blood type genetics are statistically correlated with other genetic variants that affect inflammatory signaling, immune function, and lipid metabolism. Some of the health associations attributed to blood type may be partly mediated through these linked genetic variants rather than through the ABO antigens themselves. This is an important caveat for interpreting the mechanisms, though it does not change the fact that blood type provides a clinically measurable proxy for the underlying genetic risk constellation. The most consistently replicated and most biologically well understood association is between blood type and venous thromboembolism risk, the risk of developing deep vein thrombosis or pulmonary embolism. Multiple large studies, including the mega study from the Netherlands that examined more than 5,000 patients with venous thromboembolism and more than 5,000 controls, have found that individuals with non-O blood types, meaning blood types A, B, and AB, have a significantly higher risk of venous thromboembolism than those with blood type O. The risk elevation is in the range of 1.5 to 2 times, meaning non-O individuals face roughly 40 to 80% higher venous thromboembolism risk compared to type O. The mechanism is specific and well understood. Von Willebrand factor, a protein that plays a critical role in blood clotting by binding platelets to damaged vessel walls and protecting factor VIII from degradation, is present in significantly higher concentrations in individuals with non-O blood types than in those with type O. The ABO antigens on the von Willebrand factor molecule protect it from clearance by the ADAMTS13 enzyme, with the result that A, B, and AB blood type individuals maintain higher circulating von Willebrand factor levels, higher factor VIII levels, and a more procoagulant hemostatic balance than type O individuals. This is not a trivial difference. Elevated von Willebrand factor is also associated with arterial thrombotic risk, and the higher factor C8 and von Willebrand factor levels of non-O individuals contribute to the arterial cardiovascular associations I will describe shortly. For adults with non-O blood types, the specific lifestyle implications of this procoagulant tendency are the same lifestyle factors that reduce thrombotic risk generally, but they deserve proportionally more attention, maintaining adequate hydration, which reduces blood viscosity and platelet concentration. Regular physical activity, which improves fibrinolytic capacity, the ability to dissolve clots. Avoiding prolonged immobility, particularly in the context of travel or illness. Maintaining a healthy body weight, as obesity amplifies procoagulant tendency. And the dietary omega-3 fatty acids from fatty fish that reduce platelet aggregability through their effects on thromboxane and platelet, activating factor production. None of these is a blood type-specific intervention. They are general thrombotic risk reduction measures that carry greater weight for individuals whose baseline hemostatic balance is already tilted toward clotting. Type in the comments right now what your blood type is, if you know it, and whether you have ever been told that your blood type has any bearing on your cardiovascular or thrombotic risk. Because the gap between knowing your blood type and understanding its physiological implications is one I want to help close. The second major association is between blood type and coronary artery disease and myocardial infarction risk. This association has been documented in multiple large prospective studies and has held up across diverse populations. A landmark study published in the journal Arteriosclerosis, Thrombosis, and Vascular Biology, combining data from 2 large U.S. cohort studies, including the Health Professionals Follow-Up Study and the Nurses' Health Study, and covering more than 77,000 participants followed for more than 20 years, found that compared to blood type O, blood type A was associated with an approximately 8% higher risk of coronary artery disease, blood type B with approximately 11% higher risk, and blood type AB with approximately 23% higher risk. These are relative risk increases, not absolute risk differences, and they operate on top of the major modifiable cardiovascular risk factors of blood pressure, lipids, smoking, and diabetes, which remain the primary drivers of cardiovascular risk, regardless of blood type. The mechanisms proposed to explain these associations include the higher von Willebrand factor and factor VIII levels of non-O types, which promote arterial thrombosis following plaque rupture, the differential expression of ABO antigens on endothelial cells and their effects on inflammatory signaling and leukocyte adhesion to the vascular wall, and the genetic linkage with variants affecting LDL cholesterol levels and inflammatory markers that co-segregate with certain blood types in specific populations. Blood type O's relative protection from coronary artery disease is partly explained by the lower circulating von Willebrand factor and the reduced platelet aggregability that lower von Willebrand factor produces. Type O individuals also tend to have slightly lower LDL cholesterol levels on average than non-O individuals, though this difference is modest and highly variable across individuals. For adults with blood types AB and particularly AB, The cardiovascular associations suggest proportionally greater attention to the modifiable cardiovascular risk factors: blood pressure management, lipid management, physical activity, non-smoking, and the anti-inflammatory dietary pattern we have discussed throughout this channel. The blood type associations do not create a unique cardiovascular risk that requires different management. They modestly amplify the baseline risk in a way that makes the standard cardiovascular risk reduction interventions more consequential for these individuals. And share this video right now with one person in your life who knows their blood type is AB and has cardiovascular risk factors that have not been specifically discussed with them in the context of that combination. The 23% relative coronary risk elevation in AB individuals is real enough to make the cardiovascular protective habits discussed on this channel proportionally more valuable. And if you are not yet subscribed to this channel, tap that button now and ring the bell. I want to tell you about William, 62 years old, retired banker from London, England. He came to me for a comprehensive health review. His blood type was AB, which he mentioned almost in passing when completing his health history form. His blood pressure was at the upper end of the normal range, at 135/83. His cholesterol was mildly elevated, with an LDL of 3.4 millimoles per liter. He thought his CRP was 2.1. He was moderately active and a non-smoker. By standard risk calculator assessment, his 10-year cardiovascular event risk was in the moderate range, and his previous GP had taken a watch-and-wait approach without specific intervention. When I discussed his blood type AB and the specific cardiovascular and thrombotic risk associations with him, something shifted. He had been aware of his blood pressure and his cholesterol, and had been managing them with a degree of effort that reflected his sense that the risk was moderate and the urgency was not high. Understanding that his blood type placed him in the highest risk ABO category, for coronary artery disease, operating on top of his already elevated blood pressure and cholesterol, recalibrated his sense of urgency in a way that a risk score number had not. He committed seriously to the dietary and lifestyle changes appropriate to his risk profile. At 18 months, his blood pressure averaged 126/79. His LDL was 2.8. His CRP was 1.1. His cardiovascular risk score had moved from the moderate to the low to moderate range. He told me, knowing my blood type was the piece that made everything else feel personally relevant. I told him, the blood type did not change your risk factors. It changed your relationship to the urgency of addressing them. The third association involves blood type and risk of cognitive decline and dementia. And here, the evidence is somewhat more recent and requires more careful qualification than the thrombotic and cardiovascular findings. A study published in Neurology in 2014, using data from the Memory and Aging Project, found that blood type AB was associated with a significantly higher risk of developing cognitive impairment over a 10-year follow-up compared to non-AB types, with an odds ratio of approximately 1.82, meaning AB individuals had nearly double the relative risk of cognitive decline. The proposed mechanism involves the higher von Willebrand factor and factor E8 levels of AB individuals and their potential contribution to subclinical cerebrovascular disease, the small vessel disease and microinfarction that contributes to vascular dementia, and that accelerates Alzheimer's disease progression in susceptible individuals. A subsequent genome-wide association study published in Lancet Neurology, examining genetic variants associated with Alzheimer's disease, found that genetic variants near the ABO gene region were modestly but significantly associated with Alzheimer's disease risk, independent of the APOE4 variant that is the strongest known genetic Alzheimer's risk factor. These are association findings, not causal proof, and they require replication in larger and more diverse populations before strong conclusions can be drawn. But the mechanistic plausibility through the cerebrovascular pathway, in which the higher thrombotic tendency of non-O, and particularly AB blood types, contributes to the accumulation of small vessel cerebrovascular damage over decades, is consistent with the known biology. The practical implication for adults with AB blood type is the same as for the cardiovascular associations, but now with specific emphasis on the cerebrovascular dimension. Blood pressure management is the single most important modifiable factor for cerebrovascular small vessel disease, and the urgency of maintaining blood pressure in the optimal range, below 130 systolic, is proportionally greater for AB individuals whose hemostatic profile already tilts toward microvascular thrombotic risk. Physical activity that drives cerebral blood flow and reduces inflammatory markers is specifically protective. Omega-3 fatty acids that reduce platelet aggregability and the inflammatory environment of the cerebral vasculature are specifically relevant. If you are not yet subscribed to this channel, tap that subscribe button now and ring the bell because the connection between blood type genetics, cerebrovascular risk, and the specific lifestyle factors that modify it is exactly the level of specific, evidence-grounded information I bring here every week. The fourth association is between blood type and specific metabolic and gastrointestinal risk profiles, and here I want to cover two specific findings that have clinical implications worth knowing. The first is the association between blood type A and higher risk of gastric cancer and pancreatic cancer. Multiple meta-analyses have confirmed that individuals with blood type A have a consistently elevated risk of gastric cancer compared to type O, with a pooled relative risk of approximately 1.2 in the largest meta-analyses. The proposed mechanism involves the expression of blood group A antigens on gastric epithelial cells and their interaction with the virulence factors of Helicobacter pylori, the bacterium responsible for the majority of gastric ulcers and gastric cancer, as well as differences in the gastric acid environment associated with blood type A secretor status. For pancreatic cancer, a genome-wide association study published in Nature Genetics identified a locus near the ABO gene as one of the most significant genetic associations with pancreatic cancer risk in non-smoking adults. The relative risk for blood type A compared to type O was approximately 1.32, meaning A-type individuals had about a 32% higher relative risk of pancreatic cancer. B and AB types showed similar elevations. The mechanism is not fully characterized, but may involve differential immune surveillance of pancreatic tissue related to ABO antigen expression on ductal pancreatic cells. These are population-level statistical associations, and they should not cause unwarranted alarm in individual A-type individuals. The absolute lifetime risk of pancreatic cancer is low in the general population, and even a 30% relative increase in a low absolute risk produces a small absolute risk increase. The clinical application is the same as for the Gastric Cancer Association. For blood type A adults with additional pancreatic cancer risk factors, including chronic pancreatitis history, obesity, long-standing diabetes, or significant family history, the blood type association adds to the picture and supports a lower threshold for clinical investigation if relevant symptoms arise. This is not an indication for gastric or pancreatic cancer screening beyond standard guidelines, but for blood type A, adults with a history of H. pylori infection, gastroesophageal symptoms, or relevant family history, the blood type association adds to the prior probability of risk that should inform the threshold for pursuing endoscopy or imaging, where there is clinical indication. The second metabolic association is between blood type and the gut microbiome, which has been the subject of increasing research interest as the gut microbiome's influence on metabolism, immune function, and inflammation has become better understood. Several studies have found that ABO blood type influences the composition of the gut microbiome, with blood group antigens in the intestinal secretions serving as a food source for specific bacterial species that have evolved to catabolize these structures. The practical implication of this finding is not yet fully characterized, but it provides a mechanistic link between blood type and the differential microbial processing of certain dietary components that could contribute to the metabolic and immune differences observed between blood types in population studies. The current evidence does not support specific dietary recommendations based on blood type through the microbiome pathway, and I want to be explicit that this is where the popular blood type diet overreaches the evidence. The existence of blood type-associated microbiome differences does not validate type-specific dietary prescriptions of the specificity claimed in popular literature. It is a scientific observation whose implications for practical dietary guidance remain to be determined. The fifth area is blood type and stress physiology, which is one of the less well-known associations and one that is relevant to the overall health management picture. Several studies have found that individuals with blood type A have higher baseline cortisol reactivity to psychological stress compared to type O individuals, meaning that in response to the same stressor, type A individuals produce larger and more prolonged cortisol responses. This association has been replicated in laboratory stress induction studies, and appears to be related to the differential activation of the hypothalamic pituitary adrenal axis in individuals with different ABO genotypes, possibly through mechanisms involving nitric oxide signaling and the ABO gene's interactions with inflammatory and neuroendocrine pathways. The cardiovascular relevance of this finding is that chronic cortisol elevation from repeated stress responses contributes to the endothelial dysfunction, blood pressure elevation, platelet activation, and inflammatory cytokine output that drive cardiovascular risk. If blood type A individuals are consistently producing larger cortisol responses to the same stressors as type O individuals, their cardiovascular system is under more chronic stress-related strain per stressor encountered. This makes the stress management practices I have discussed throughout this channel, specifically the morning buffer period before engaging with stressful content, the breathing practices that reduce sympathetic activation, the sleep quality optimization that restores cortisol balance overnight, and the physical activity that produces cortisol washout, proportionally more important for type A individuals. Not as a substitute for medication or medical management of cardiovascular risk, but as a specific lifestyle investment whose cardiovascular return is higher for those whose cortisol reactivity is constitutionally elevated. Here is the practical framework for applying this information to health decisions, with the important caveats about proportionality and evidence quality. Blood type O is associated with the lowest venous thromboembolism risk, the lowest cardiovascular disease risk, and the lowest cognitive decline risk among the ABO types in the available epidemiological literature. This does not mean type O individuals are protected from these conditions, or should be less vigilant about their management. All adults over 60 should be managing cardiovascular, thrombotic, and cognitive risk actively. The relative protection of type O operates on top of the same modifiable risk factors that determine outcomes for all blood types, and type O individuals with elevated blood pressure, diabetes, and sedentary lifestyles face substantially higher cardiovascular risk than type B AB individuals with excellent metabolic health and active lifestyles. Type O does carry one specific association worth knowing: a higher relative risk of peptic ulcer disease. The H antigen expressed on gastric mucosa in type O individuals is specifically bound by the adhesin BABA of Helicobacter pylori, facilitating the bacterium's attachment to the gastric lining. This means type O individuals are more susceptible to H. pylori colonization and have a higher risk of developing the peptic ulcers that H. pylori causes. For type O adults with a history of gastric discomfort, dyspepsia, or gastric ulcer, H. pylori testing and, if positive, eradication therapy is proportionally more relevant to their long-term gastrointestinal health than for non-O individuals. Blood type AB carries the highest relative risks for coronary artery disease and cognitive decline among the ABO types in the current evidence. For AB adults, the cardiovascular and cerebrovascular protective lifestyle habits, specifically optimal blood pressure management, regular aerobic and resistance exercise, omega-3 fatty acid adequacy, anti-inflammatory dietary pattern, and stress management, deserve the highest priority and the most consistent application. Blood types A and B occupy intermediate positions in most of the risk associations. Type A individuals may benefit from specific attention to the cortisol reactivity dimension, making stress management practices proportionally more important, and to the gastric cancer association where relevant clinical history is present. For all non-O blood types, the thrombotic risk awareness, specifically adequate hydration, regular movement especially during travel or illness, and omega-3 fatty acid intake for platelet aggregability reduction are consistently relevant. We want to add one more specific finding from recent research that is relevant to adults over 60 with any degree of kidney function concerns. A study published in the Journal of the American Society of Nephrology, using genetic data from more than 130,000 adults as proxies for blood type, found that genetically inferred non-O blood type was associated with a modestly higher risk of chronic kidney disease progression compared to type O, with the association mediated partly through the higher von Willebrand factor and the endothelial dysfunction associated with non-O blood group genetics. For adults who are already monitoring their eGFR and kidney function, as we discussed in the 6 Health Numbers video, this finding adds to the rationale for the blood pressure and metabolic management that protects kidney function, and makes those interventions slightly more consequential for non-O individuals than they would otherwise be. The overarching message is not that blood type determines outcomes. The effect sizes are real but modest, and the lifestyle factors discussed throughout this channel are far more powerful determinants of cardiovascular, cognitive, and metabolic health than blood type genetics. What blood type may provide is a modest but meaningful signal about where an individual's biological vulnerabilities are concentrated, allowing them to direct the proportionally greatest effort toward the protective habits most relevant to those vulnerabilities. 4 things to carry away. First, the ABO blood group is not simply a transfusion compatibility marker. The ABO antigens are expressed on endothelial cells, platelets, and other tissues, and the ABO gene region is associated with von Willebrand factor levels, inflammatory signaling, and lipid metabolism in ways that produce real but modest differences in cardiovascular, thrombotic, and cognitive risk between blood types. Second, the most robust association is between non-O blood types and elevated venous thromboembolism risk, mediated by higher von Willebrand factor and factor VIII levels. For AB and AB individuals, the thrombotic risk reduction lifestyle habits, hydration, physical activity, avoiding prolonged immobility, healthy weight, and omega-3 fatty acids carry greater preventive weight than for type O individuals. Third, blood type AB carries the highest relative risk for coronary artery disease and cognitive decline among the ABO types in the current evidence. For AB adults, cardiovascular and cerebrovascular protective habits are proportionally more consequential than for O adults, not because they require different interventions, but because the return on those interventions is greater for those who start with a modestly higher baseline risk. Fourth, blood type genetics represent one modest input into a health risk picture that is overwhelmingly shaped by modifiable lifestyle factors. The value of knowing your blood type's associations is not to feel either protected or condemned by your genetics. It is to understand where proportionally greater investment in specific protective habits may yield proportionally greater return for you as an individual. Your blood type has been part of you since your DNA was first assembled. What it predicts about your health risks is modest in absolute terms, but real enough to be worth knowing, and the lifestyle factors that modify those risks are the same ones that benefit everyone, applied with the specific emphasis that your blood type's profile suggests is most worth making. Share this video with one person in your life who knows their blood type but has never been given the specific cardiovascular and thrombotic context I have described today. And subscribe to this channel because every week I come here with one purpose: to give you the specific information that makes your personal health picture clearer and your health decisions more targeted. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.